Thanks very much, Peter, and thanks for the opportunity to be here today. Breathlessness is a huge challenge across our community, and when we think about the patient population we treat, it is the lived experience for most of the patients that we've talked about in this session. The real question is, in addition to disease-modifying therapies, what are the symptomatic things that have an evidence base that can predictably and safely help our patients? These are my disclosures. One of my colleagues, Miriam Johnson in the United Kingdom, lives in an area where there's a local government area that still has a smoking rate in 25 to 34-year-old women of 70%, 70%. And so it's a frighteningly good place to do research on breathlessness. And one of her participants said, "It is an effort just to be." And I think that typifies the challenges that the patients that you and I see have. The exciting thing is that today I'm doing an update on breathlessness. 12 months ago when I spoke at this conference, there was new and emerging evidence, but the last 12 months have been incredibly productive around the world, and there's new evidence on which to reflect. So over the next little while, there are 4 things at which I would like to look. The first of those is the definition of chronic breathlessness. You and I probably take this for granted, but haven't thought through what that would look like. When we think about this, we're talking about the transition from something that for us is subconscious and automatic to a process where it becomes conscious and requiring both concentration and effort. And for many of the people we're talking about, this is not over a period of weeks or months. It's over a period of years or indeed decades. And so as we think about that in our patient population, what is that lived experience? My colleague Sarah Booth from Cambridge coined this phrase more than 15 years ago: breathlessness is the pain of non-malignant life-limiting illnesses. And I think that captures not only respiratory disease, but cardiovascular disease, and indeed for many people, neuromuscular disease. In all 3 of those groups, we see progressive breathlessness despite optimal treatment of the underlying cause. So in the last 12 months, there's a publication that really has brought together experts from around the world to define a syndrome called chronic breathlessness. It persists despite optimal treatment of the underlying causes, and in the words of the World Health Organization, results in disability. Importantly, that Delphi process of experts from across 4 continents did not require a duration for that chronicity. That is, from today, this person is going to have breathlessness because what I have done has optimized the underlying causes, and we're not going to see further amelioration of that symptom. And so when we think about that, what is the impact? I really like this study that used the United Kingdom Clinical Practice Research Data Link, which brings together primary care using the same electronic database with agreed measures, including in this case, the Medical Research Council breathlessness scale. They've got data on just over 40,000 people and who had COPD and had their MRC done. 46% had moderate breathlessness, but predictors of breathlessness, not surprisingly, included severity of airflow. But importantly, 32% with mild airflow obstruction also had moderate to severe breathlessness. So the correlation is not there all of the time. And it comes back to making sure we take a history of this person's lived experience. What were the other predictors? Being female, and again, we've seen that in population study after population study right across the world. Age, obesity, and this is one group that had published on obesity at a population level and its relationship to breathlessness. Our group also has published on that in South Australia. And unfortunately, and not surprisingly, as your BMI goes up, so does your breathlessness also. And the number of moderate to severe exacerbations was also very directly related. Graphically, when we look at that, we have the severity of COPD across the bottom, and then in each column, the Medical Research Council scale levels. That means that there are a proportion of our patients in clinical practice on a day-to-day basis who will predictably have severe shortness of breath. Beyond simply the shortness of breath, I do like the work from Jason Boland now in Hull. The issue of social isolation is not to be underestimated. These patients describe a social death long before their physical death. Not only are they no longer able to get out to see other people stop coming to see them. And so that concept of a social death 18 to 24 months before their physical death is very real. As you know, the Medical Research Council scale, grade 5, or modified Medical Research Council scale, grade 4, means that you're breathless so that you're either housebound or breathless doing things such as dressing and undressing, bathing or preparing meals. This is severe disability, and again, the chronicity of that is not to be underestimated. So are there opportunities that we can take in clinical practice to better recognize this and indeed better respond to it? So the first question is, do we ask, are you breathless? Which probably for most of us translates to a question of how intense is your breathlessness? And you and I can see patients who are visibly distressed by their breathing saying, no, not breathless. And you wonder why that dissonance and why that dissonance so consistently. And I'd like to suggest that perhaps the question should be, what have you given up in order to avoid being breathless? Because you get totally different answers. Well, I gave up gardening 6 months ago. I gave up walking the dog 4 months ago. I haven't had sex for a long time because of breathlessness. But if you ask me, am I breathless? No, because my world has shrunk. I do everything I can to avoid breathlessness. And so as we teach the next generation of practitioners, we really do need to think about that. When we think about the underlying causes, the challenge is that people are also going to understate this, particularly if it's due to COPD, and they perceive that it is self-inflicted, insidious, and patients in that setting believe that people limit their response in wanting to reach out and help them. So even the underlying diagnosis will lead to different perceptions by patients and different abilities, therefore, to communicate it. This work by Marilyn Giesels, who was at King's College London at the time she did it, was from in-depth interviews of people with COPD. One of the biggest challenges they identified was no one talked about the future. The future was either assumed or was hidden, but it wasn't discussed. And we've just heard we should refer early if we're going to assess people for things such as transplants, but that requires also a very overt discussion about prognosis. And how we have that discussion early on as we see disease progression, we personalize it for that person in terms of the rapidity with which it's happening, becomes a really important issue for us. When we think about the impact of breathlessness, we also need to think of the health services impacts. And these are recent data, again, from Yorkshire, interestingly enough. It's amazing what people will do for their PhD. And again, all my references have dropped off the bottom of your slide, so we can go through those later. They are all referenced. Anne Hutchinson and 2 colleagues sat round the emergency department solidly for 18 days. So it was covered at all times. They looked at major and minor presentations. When we look at major presentations, interestingly, 1 in 5 major presentations was due to breathlessness. And the vast majority of those were acute on chronic breathlessness. That is, that the person was breathless most of the time and had reached a threshold where they needed to have additional help, and so in general rang the ambulance and came to the emergency department. The challenge for us is that having come to the emergency department, our response is often, well, let's admit you for a couple of days. And yet when we look at the data, the number of people who had severe breathlessness at the time they reached out to seek help was more than 1 in 2. But indeed, by the time they got help, it was down to 1 in 12 still had severe breathlessness. So it settles and settles surprisingly rapidly for many people. And so the natural consequence of these research findings is, can we do more to aid people in actually self-managing acute on chronic breathlessness in this sort of setting to relieve some of the pressure on the emergency department and certainly to affect length of stay. Breathlessness remains, as we've seen in the last couple of presentations, a really good prognostic indicator. And in this population-based study, so this was, again, as with our South Australian Health Omnibus data, unrelated to health service contact, your hazard ratio was almost 10 times as high if you had, in order to experience death from COPD, because you had high breathlessness scores. And that was underlined with a really nice study that compared prognosis when you looked at severity of COPD on the right-hand side with prognosis relating to breathlessness on the left-hand side. A far better prognostic indicator for the majority of our patients. That is, if it's severe, it's a very good prognostic indicator. To the work that we've done, and this was Jackie Bowden, not Jeff, but both South Australians. Importantly, what we saw when we looked at the whole of the population was that age, marital status, physical activity, obesity, gender, and social disadvantage were all significant predictors of breathlessness across the community. And in more recent data from across the community, if you look at the short form 12 quality of life tool, which looks at both a physical component and a mental component, across the bottom on the x-axis, we've got the Modified Medical Research Council scale, 0, 1, and 2 to 4. On the left-hand side, we've got the physical component, and on the right-hand side, we've got the mental component. A really marked reduction in both of those as breathlessness gets worse at a population level, again, independent of health service access. The other potential missed opportunity, and these are silver chain data from Western Australia, we've worked with them over the last decade looking at their prospectively collected symptom data from community nurses seeing people across, for us, the last 120 days of life, but these are the last 7 days of life. And there are a couple of things to look at. Firstly, people with respiratory disease generally had much higher levels of breathlessness. So on the y-axis, 0s at the bottom, 10s at the top from numerical rating scales. And this is 33,000 data points for more than 12,000 patients prospectively collected. So a really large data set. And despite symptomatic treatment, this breathlessness is moderate, bordering on severe for many people. But interestingly, these data, although adjusted for lots of factors, were not adjusted for functional status. And we're about to publish, so here's the preview of one of the previews of the day. We're about to publish data from the same group, subsequent 3 years. On the left-hand side, the first two groups of columns are people with no known cardiorespiratory disease and very poor functional status on the far left. Second group of columns, reasonable functional status. Now, that tells me a number of things. Firstly, there are a group of people who still die suddenly despite the fact that they have an advanced life-limiting illness. So that concept of sudden death is not a surprise to anyone in this room, but is a surprise to many of my colleagues in palliative medicine. On the right-hand side, the two groups of columns are those with poor level of function, but known cardiorespiratory disease. And on the right-hand side, those with good levels of function. These are self-caring people who in the last 3 weeks of life prospectively collected data, and lots of it. So in this we've got, again, 48,000 observations in almost 7,000 patients. We see that week 3 before death, breathlessness is marked. Week 2 before death, breathlessness is marked. And in the week before death, breathlessness increases quite dramatically in those last few days. I'd like to suggest that that is a missed opportunity, that we probably have a group of people where we are getting warning of their death. They're functioning reasonably well. They're reasonably independent. They're saying my breathlessness is getting worse, and they're still dying, because I expect we're not responding. And given the autopsy data from particularly Wales, looking for thromboembolic disease in this patient population, and the documentation of arrhythmias, we've got some interesting work to do in potentially better responding to that group of patients. So what's changed in the evidence base for doing something symptomatically? Going the wrong way. Symptomatically, let's look at the anxiolytics, because there's some interesting data. These are prospective data from Deb Dudgeon in Hamilton, Ontario. Almost 20 years old, but I'm not aware of a consecutive cohort study that has been done since. 100 consecutive patients with cancer, and only one person had anxiety as the only cause of their breathlessness. Doesn't mean that they didn't have anxiety as part of that, but as the only cause of their breathlessness. So we've got widespread use of benzodiazepines, and yet the Cochrane review suggests that bringing the randomized controlled trials together, we still have absolutely no signal that the benzodiazepines help with chronic breathlessness. Widespread use, very poor evidence base across a number of diseases. And so not a lot of studies, the studies are not large, but we have no signal that would suggest that we should be rushing out to use benzodiazepines or study them further in people with chronic breathlessness. Acute breathlessness, potentially different, but at the moment there is no evidence of a beneficial effect, with lots of side effects to be experienced in that space. The largest study of anything symptomatically for the pharmacological treatment of breathlessness is in fact buspirone, which is a non-benzodiazepine anxiolytic. And this was a large study in people with cancer, 432 participants, a fairly typical population for us, multi-site study, MMRC of greater than or equal to 2. And importantly, again, up to 4 weeks of study, one-to-one randomization, and in those previous measures that we saw, in oxygen cost diagram, in state trait anxiety inventory, and in breathlessness, we see absolutely no difference between the two arms of this study. And when we look at that controlling for baseline scores, borderline, but again, no difference in breathlessness and no difference in state trait. So at the end of the day, we really have the challenge that we've seen no signal there. The Palliative Care Clinical Studies Collaborative, a national, the world's largest multi-site collaborative for symptom control studies, has just completed a phase 3 study of sertraline versus placebo. This was titrated as a blinded study. Sertraline, because it does have an anxiolytic as well as an antidepressant effect, People were randomized 1-to-1 to sertraline or placebo. It was titrated up over the first 9 days to try and get people to 100 milligrams. The primary outcome was reduction in breathlessness in this study. Again, a large, adequately powered study. Bottom line, no difference in quality of life, no improvement in performance status, no difference in anxiety or depression, and no change in overall survival. That was measured out to 28 days as the blinded study, with the offer of a blinded continuation until the last participant had their last data collected. So we have some long-term data there. The only sub-analysis on which we're waiting are the people with high levels of anxiety at baseline, and we should have those data in the next couple of months. The bottom line is sertraline, certainly for its primary outcome, is not showing any advantage over placebo in reducing breathlessness in a patient population that is fairly typical to the people that you and I see in this room. What about opioids? You'll be aware of the Canadian Thoracic Society Clinical Practice Guidelines for chronic breathlessness. In the yellow, optimize the treatment of underlying causes. In the green, optimize the non-pharmacological therapies. And in the blue, initiate and optimize opioid therapies. We've seen a hell of a change in the gold statement from 2001 through to 2006, through to 2011. Through to 2017. Narcotics are contraindicated in COPD, 2001. With no caveats, in 2017, opiates can relieve breathlessness. And so why has that changed? We still have no medication registered with any of the regulatory bodies around the world for the symptomatic treatment of chronic breathlessness. Now, that's pretty challenging in 2017, isn't it? To think of the burden that we see across the community, that you and I see in clinic on a day-to-day basis, and we still don't have a single pharmacological agent that is registered for the symptomatic treatment of breathlessness. Magnus Ekstrom did this meta-analysis, which was published in 2015, and there's no doubt that when you look at the systemic administration of regular low-dose opioids, you see benefit, and particularly when you look at that in steady state, it is a benefit that symptomatically standardized mean difference translates to a clinically significant difference of a reduction of about 1.5 points on a 0 to 10 numerical rating scale. A clinically significant improvement is about 0.9 of 1 point. So it's both clinically and statistically significant. There have been a couple of systematic reviews published, and we updated one that was published in as a Cochrane review, where we looked at random effects rather than a fixed effects model, and took into account a crossover rather than treating crossover studies as parallel arm studies. Again, you see down the bottom of this forest plot very clear benefit in favor of regular low-dose opioids. Our group is just publishing a large multi-site study of extended release morphine compared to placebo, low dose, regular. Sites right across the country, lots of people, and we acknowledge the funding of the Australian Government Department of Health and Ageing. To look at efficacy and safety as well as predictors of response. Now, we deliberately chose using an extended release preparation. If you look at the green, which is a true controlled release, sustained release preparation, versus blue, which is a controlled release, versus red, which is immediate release, you can see that the peaks and troughs are far smaller, lower peaks, higher troughs. And so that was very deliberately chosen, 20 milligrams once a day, with docusate and senosides A and B versus blinded opioid and blinded placebo. Our Human Research Ethics Committees required us to have immediate release solution available to all participants, and you can imagine that's a significant contaminant in the data that are available to us. So no overall statistically significant difference between the two arms for breathlessness now. However, when we look at subgroups, again we see that people with a modified Medical Research Council scale score of 3 or 4, COPD, are much more likely to respond. And when we look at that in the forest plot, MMRC 3 or 4 is significantly in favour of treatment. And when you add COPD into that, although the numbers are smaller, the point estimate again moves in favour. If we look at that in terms of absolute difference with that cutoff point of 8.9 millimetres on a 0 to 100, visual analog scale, again, worst breathlessness is the thing that improves and improves both clinically and statistically significantly. People were more likely to use immediate release oral morphine solution on an as-needed basis in the placebo group than they were in the morphine group. What about the safety of this? Again, Magnus Ekstrom, you've got to love the Swedes. This study, which is a large prospective cohort study, the results section start with those immortal words, "There was no loss to follow-up." Who can say that for a consecutive cohort study but the Swedes? They know where everyone is. And so we were able to follow up people who were on long-term oxygen therapy, who were subsequently started on either an opioid or a benzodiazepine or both. And as you can see, in terms of admission to hospital, no signal for opioids. A big signal in mortality for benzodiazepines, again, not cause and effect, but association. And in terms of mortality, nothing up to 30 milligrams of morphine daily, and that was a priori chosen as that indicator. What about on other effects? Diana Ferreira has done a really nice meta-analysis looking at the effects on driving and opioids, a major concern to people around the world. Inclusion criteria, really looking at chronic pain or chronic breathlessness, taking regular therapeutic opioids and not contaminating that with as-needed recreational or illicit use of opioids, which is the really big distinguishing factor between this review and others. Lots and lots of records screened, down to 3 studies matched to the criteria. No significant impact of regular therapeutic opioid agonists on people's driving-related behaviour. Interestingly, to flip it over though, if you had more severe pain, your driving was more likely to be impaired. So in fact, symptom control may allow a person to concentrate more effectively while driving. So the bottom line really is this. Chronic breathlessness, where the underlying causes are optimally treated, is a major problem across our community. And as we think about that, there are missed opportunities, I think, because we don't recognize it. It is silent, it is a Cinderella symptom, and there's much more that A, we can do to recognize it, and B, that we can do to respond. The evidence for anxiolytics is not there, despite some large, well-powered studies and at least one meta-analysis. By contrast, regular, low-dose, extended-release morphine has an evidence base for its safety, it's biologically plausible, and although we haven't covered it today, we did last year, really good basic science to support its widespread uptake into clinical practice. Have a great day.